And at this time, I'm more than happy to answer any questions that you all might have.
Well, thank you, Patty, for that great presentation. And yes, we do have some time for Q&A. So I just wanted to remind everyone that if you have any questions, feel free to submit them and we will get to as many as we can. Now, the first one here, Patty, so you mentioned that more intensive therapy is not the norm in skilled nursing, and get into a bit more about why that is.
Yeah, that's a great question, Amy. And this is like the $1,000,000 question, right? So the evidence shows that it generally in healthcare, not just in rehabilitation, takes 17 years for what we know from science to actually be the care that patients receive consistently. That's 17 years. That's a really long time. And because of that, there's actually a whole science now, implementation science, that's been developed, and performance improvement work is often grouped in with that. That's really designed to address that very thing. How do we change clinician behavior? And when you think about human behavior, and clinician behavior as part of that, is you generally have intrinsic motivators and extrinsic motivators when we can think about that. And so, of course, what we try to do with our clinicians is be sure to give them the knowledge, the why, talk with them about skills, to fill any skills gaps that they might have, and then really you were really tapping into those intrinsic motivators, both for our clinicians and our patients and their families, to understand what's the value of these higher intensive elements of care, what they can get from it. The other side of the coin is those extrinsic motivators. And I know one of the things that clinical practice guidelines are beginning to do with payers is payers are beginning to look at some of those clinical practice guidelines and dig in a little bit more, although I think there's still actually opportunity to do more of that, to actually dig in and look at what is being provided. Is it consistent with the clinical practice guideline? And, that's a really powerful extrinsic motivator to clinicians, payer rules. So I think that we're just barely putting our big toe into that side of things, but it's beginning where they're looking for some of those synthesized documents and then using that to say to clinicians, it doesn't look like this was provided. Let's talk about that.
And then you kind of touched on this a little bit, but what is being done about, having intensive therapy be more of the norm in skilled nursing?
Thank you. Yeah. So it's really at this point a kind of an individual effort. What we've done is we've invested quite a bit. We have knowledge brokers who are expert clinicians, and they go in and work side by side with clinicians. They model behaviors. They help the clinicians see where they're hitting the mark with those behaviors and where there's a gap and how they can modify that. So we've been pretty purposeful about building some infrastructure to help the clinicians, again, fill any knowledge gaps, fill any gaps in skills that they may have. And then how do you build that by looking at, always there's accountability. That's always kind of a piece of knowledge translation interventions. And so we can do that through audit, feedback, that sort of a thing. So what we've tried to do, and different folks are doing it differently, what we've tried to do is really invest in the infrastructure and the personnel that can help our clinicians move in those directions.
Mm-hmm. And another question here. So the measures you used in the analysis are different from the quality metrics used by CMS. How do you think your data relates to the measures collected by CMS?
Yeah, so that's a good question. So, we have Section GG that's being used across the post-acute environment. And I hope that you saw in the figure that Section GG is not as robust in identifying these differences in patients. Again, because we can teach compensatory strategies and remediation to get people there, it doesn't identify those patients who really need those remediation strategies to prevent health and mobility decline. And that, to me, is a part of the really big picture. It's about more than just getting the patient out of the community and into, out of the building to home. And so, so I think that what we see is that these measures are particularly valuable. I, of course, am always thinking, well, we could change CMS. And actually, these are not hard measures to collect. So you could think about really looking more at the longest distance walked. That's a pretty good representation of a 6-minute walk test. We look at transfers. We could say yes or no. Can the patient stand without using their upper extremities? And then finally, walking speed. The data on walking speed as an indicator in older adults is so powerful that it's often referred to as a 6th vital sign. And it really is pretty easy to capture, and it wouldn't take actually that much to make some of these measures that are more robust in really identifying differences in rehabilitation measures. It really wouldn't be that difficult to get them embedded into practice.
And then in the title of your talk, you state that physical performance is more important than health condition when predicting outcome from rehabilitation. What role, if any, do you think the health condition plays in responsiveness to rehabilitation?
Yeah, also a good question. I think what happens is that, so there have been a number of studies that have looked at this. So they've looked at comorbidity indices and how that relate to functional performance, and they don't pan out very well. And as a therapist, you can always think of like two patients who have the same set of medical diagnoses and they look completely different. Where I think medical diagnosis comes into play is neurological diagnoses, and we see this in our data. When you have an illness or a condition that's primarily affects the motor sensory system that's needed for mobility and activity, that's going to be a problem. Not always, though. So again, there are some data like stroke that would tell you about prognostic indicators there, so you can dig into that a little bit more. And then the other side that we see is we do see some effect of multiple health conditions, but it seems like it's when more health conditions get to end stage, where we simply, and often we are left to figure this out by response to activity or exercise. When we attempt to get the heart rate up into that moderate heart rate training zone, something goes wrong. The heart rate, the rhythm changes. It goes up too high. Blood pressure changes in an unsafe way. And when we see that over time, that's usually how we're measuring that basically the patient's systems, there are multiple systems that are impacted by their health conditions, are at a level where they simply cannot be responsive to these higher level of interventions. So that's kind of where we are. And it's actually kind of a big black box of rehabilitation. And I think definitely worth additional study in understanding, are there some factors that regardless will have an impact, or is there a certain, like you have to have 3 conditions that are bad, for example, before it impacts your rehabilitation outcome? That's the type of data that we might need to answer that question more specifically.
Mm-hmm. And then you showed us a figure related to cognitive status in the different patient groups. How does cognition impact the patient outcomes?
Yeah, I showed you some results of some pilot work where we did high intensity stepping with our own patients in skilled nursing. And that was, we were able to slice and dice that data by cognitive status. And what we found was there was no relationship to responsiveness in that intervention based on cognitive status. Now, when we aggregate the data over more patients, we certainly see that our lower performing groups of patients have more cognitive impairment, but really what it comes down to is it's therapists and how they change their approach to maximize responsiveness to those physical interventions. So some things that we know help: blocking practice, doing things in the same way, keeping instructions simple and the same. It's really about just gaining skill as a clinician, recognizing that if we build capacity, even with a patient with diminished cognition, it's still protective for them and may even be more important for them, say for fall risk, where because of their cognitive processing, they might be more at risk. If we can help build the physical stuff to be more protective, then that's really what the goal is. It takes a little more effort. It takes more patience on the part of clinicians, but cognition by itself is not one of those things that says it's absolutely, when it's providing these more intensive interventions is not going to work. That's not the way it works.
So it looks like we are out of time here, Patty. So just wanted to thank our audience for joining us, and of course to you for the great presentation. And then a big thank you to our sponsor for this webinar, Infinity Rehab. And for our audience, don't go too far. Our next session, How SNFs Can Drive Therapy Upside in the PDPM Era, begins in 30 minutes. So see you there.